Hey, this is Dr. Muscatello again. Lucky for you guys, if you've come this far, we've gotten through most of the hard stuff, so it's sort of all downhill from here. We have talked about processes, really sort of the more difficult stuff. Now we get to talk mostly about function in the remainder of the chapters, and we also get to talk about disease states. So that's all the kind of stuff that you guys like learning about, we like teaching about, and USMLE likes asking questions about. Okay, it's just a quick recap of what we covered in the last chapter. We are just going to talk a little bit about the primary humoral response. Again, recall that the first wave of activated B cells that are going to be released from the lymphoid tissues during an immune response are going to be plasma cells that are making IgM. We know that. We know it's important. We know that IgM is indicative, if we find it, of an acute infection. Now, it's really of no coincidence that IgM is first, because if we take a look at the gene structure here, we can see that mu is actually the first constant region downstream from the variable region. So that actually should make perfect sense. And recall, until we come in contact with antigen, the only two isotypes we are going to be able to make are going to be the IgM, which is encoded by mu, and the IgD. So anywhere past that delta, right here, we don't have access to until we come in contact with antigen. So let's talk a little bit more about IgM and the primary humoral response. What is really sort of cool about IgM is that when it's secreted from a plasma cell, it's secreted as a pentamer. Now, we've already looked at IgM, what it actually looks like on the surface of a B cell as its B cell receptor, which is as one monomer of an antibody molecule. But in the secreted form, it is bound together by a chain called the J chain, giving us a pentamer that has the potential to bind 10 antigens. Now, here's an important point. Those 10 antigens, you have to remember, have to be identical. It's not like each one of these variable regions can bind different antigens. They all are specific for the exact same antigen. One thing that I hope you are appreciating about the immune system is how actually really clever this system is. And just when we need sort of a new type of immune response or something different, the immune system is really capable of giving that to us. I really find that interesting with IgM because the IgM pentamer is, again, secreted from plasma cells early on in an infection when we actually have more antigen than antibody. So that IgM has 5 times the capacity for binding epitopes. And what happens is, because it is present early on in the infection, it is really good at sort of soaking up antigen pretty much just like a sponge. So therefore, that IgM that just happens to be there during our primary immune response is critical in trapping all of that excess antigen very early during the immune response. Once we shift to some of the other isotypes, we don't have any other isotypes that are secreted as pentamers, but the antigen concentration is actually going down. And we're switching isotypes to different effector functions so that we can eliminate very specifically the antigen that is left. Just want to mention a couple of definitions so that you understand sort of the differences in some of the terminology they may use within some of the questions. First, just going to talk about affinity, which really just deals with the strength of the interaction between the antigen and the antibody. This affinity we already talked about through the process of affinity maturation gets better during an immune response. Now, what we see with IgM is something called a high avidity, and the avidity actually increases with the addition of additional binding sites. So, for example, IgM, we already said, has the capacity to bind 10 antigens. So of all of the different antibody isotypes, IgM has the highest avidity. Now, I'm hoping you already know, if I were to ask which antibody has the second highest avidity, you would tell me IgA, because IgA, when it's secreted from plasma cells in the mucosa, is expressed as a dimer, so it has the potential to bind 4 antigens. Affinity is higher when we go away from IgM and move towards IgG, because at the same time that affinity maturation is happening, class switching is happening. So IgM never really gets the chance to become really high affinity, but that's okay because, as we already said, it's really important to have IgM there at the beginning of immune response to really soak up all of that excess antigen that is present. An additional function of IgM is the activation of the classical complement pathway. And IgM is actually really effective at doing so. And again, we'll sort of think about this. We're going to have a lot of IgM at the beginning of an infection. We only actually need one IgM molecule to activate classic complement. That's great because we're going to want the complement activation because, remember, it also helps us to remove immune complexes, it helps us to opsonize, and it certainly aids in the inflammatory response. Now, serum IgM, unlike IgG, cannot act as an opsonin and cannot be a mediator of ADCC. This is where we get into a little bit of the difference in effector functions between IgM and some of the other antibody isotypes. How important is class switching? It's actually pretty important because if we are unable to class switch, we can actually wind up with an immunodeficiency disease known as X-linked hyper-IgM syndrome. This is one of the humoral deficiencies, and we are going to come back to all of these immunodeficiencies in a future chapter and really sort of give you a good way to sort of compare and contrast them so you know, no matter what vignette they ask you, you'll be able to figure out which one is which based on the data that they give you and based on the clinical presentation. But just as the name suggests, X-linked hyper-IgM syndrome is characterized by a deficiency of your other antibody isotypes like IgA, IgG, and IgE, but with elevated levels of IgM. Hey, if you can't make any of the other isotypes, why not just make as much IgM as possible? So the IgM levels can really get quite high in patients with hyper-IgM syndrome for this reason. It is an X-linked recessive as far as USMLE is concerned. There are other forms that exist, but they're certainly not going to test you on those. We're going to recall it just as an X-linked recessive disorder. The defect in hyper-IgM syndrome is actually on T cells, and it's a defect in CD40 ligand. You'll recall CD40 ligand is expressed on activated T cells. We mentioned it was required for class switching, and it was also required for a memory response and the formation of germinal centers. So as you can see, the patients are failing to make germinal centers. We don't get a good memory response, and in general, children are going to suffer from recurrent respiratory infections. Not just pneumocystis, but children that do have hyper-IgM do tend to suffer from recurrent pneumocystis infections.
As IgM is doing an incredible job soaking up all that excess antigen and initiating the classical complement pathway, the B cells that have remained in the germinal center are taking the time to undergo class switching. Now, remember, a class switch is going to be dependent upon the cytokines that are produced with respect to a pathogen. But with that said, a majority of the time, the isotype switch is going to be to IgG. Now, IgG, and we're going to look at the structure on the next slide, is always secreted as a monomer. And this is probably the most versatile isotype that one is going to find. It has some overlapping functions with IgM and also has some overlapping functions with IgA. A majority of the IgG that is produced is in response to interferon gamma, which is generated by our Th1 cells. So again, you go back in your head and say, well, why would I have a Th1 response? The Th1 response are geared primarily towards viral infections and intracellular bacterial infections. Just to remind you of the overall structure of IgG, again, it is a monomeric antibody. Like all of the other antibodies, it has two very well-defined areas. It has its idiotype, where we have the antigen binding sites. And remember that idiotype refers to the specificity, and any one is only going to recognize one antigen. Also recall that we have the isotype, which is determined by the heavy chain constant regions down here. So again, this is sort of a constant between all of the different isotypes. So what is it about IgG? Well, IgG is always the most abundant isotype found in the bloodstream and is extremely versatile. What we're going to see is that IgG is a multitasker, okay? It can help activate complement, or it can serve one of many other functions. Before we leave this slide, again, Dr. Moscatello was kind enough to remind you of some of the definitions associated. Just remind yourself with IgG, it has a higher affinity than my IgM, and it has a lower avidity versus pentameric IgM or even dimeric IgA. If you recall when Dr. Moscatello was going through the various constant region exons that are going to be found within the heavy chain gene, there were several types of IgG. And you're probably asking yourself, oh man, I remember when I learned these, I have to learn what all the different sub-isotypes of IgG do. You really do not need to know that currently for the step 1. Instead, what we would like you to know is that, yes, there are 4 different sub-isotypes. The most prevalent in the bloodstream is IgG1, and you become less and less frequent as you go down the list from IgG2 to IgG3 and then IgG4. Let's go ahead and describe some of the functions of IgG. Now, again, I said sometimes IgG will share a function with another isotype. Principally, what I'm talking about here is that IgG is capable of activating the classical complement pathway, just like IgM does. But you know what? IgM just does it better because IgM is very high in its valency and is capable of binding multiple antigens on the surface of a pathogen, and just having one molecule allows it to activate the complement pathway, whereas you need a minimum of 2 IgG binding to that same pathogen. So IgG is capable of doing this, but IgM is much better. IgG also serves as an opsonin. This is really a review point. Dr. Moscatello talked to you about the 2 most important opsonins for enhancing phagocytosis. Remember that our phagocytes tend to express on their surface that CD16, which is going to be specific for the constant region, IgG. So that is another function. This is probably one of the more important functions of IgG, in that it serves as a neutralizing antibody. And if you are able to neutralize a pathogen, you can essentially halt that pathogen from adhering to a cell surface and infecting. It also has the capability of neutralizing toxins. So if you think of something that's going to enter into your GI system, if you've had a previous exposure to that particular toxin, you will be able to neutralize it. Or if it's introduced directly into the bloodstream. And it mediates a very unique process this antibody-dependent cellular cytotoxicity, which we're going to talk about in detail when we get to cell-mediated immunity. And then finally, IgG is the only, hear this, ladies and gentlemen, notice how high my voice just got. IgG is the only isotype that can cross the placenta. When we start talking about immunizations, we'll talk about how important that transfer of IgG is during the first year of an infant's development. Another option during class switching is to class switch to isotype IgA. Now, if you see an isotype switch to IgA, you need to assume that you are dealing with B cells that are within the submucosal arena. And this is going to occur much more commonly in these areas than you're going to see in the lymph nodes or the spleen. So I always say, if you're thinking IgA, think anywhere that is wet and or sticky, and you will find your IgA. Now, IgA is typically produced, secreted, and assembled into a dimer. And the dimer is held together by a joining chain. This is the same joining chain that is utilized in order to establish the pentameric IgM. At the mucosal layer, IgA is the major protective defense. And I actually find IgA to be a little interesting because it does not follow the same rules that we see when we are isotype switching to something like IgG or IgE, which is going to be dictated by specific pathogens. So remember, I get predominantly IgG when I have an intracellular infection. I get predominantly IgE when I have a parasitic infection. With IgA, the isotype switch is rather determined by the location of the infection. And again, IgA is associated with the mucosa. So if you have a virus, a bacteria, a fungus, or even a parasite that is infecting the GI tract, the GU tract, or the respiratory tract, the predominant isotype switching is going to be to IgA. And that is because the infected cells are going to produce high levels of TGF-beta, which drives isotype switching to IgA. Now, there is another cytokine, IL-5, which is absolutely produced by Th2 cells that has a lesser effect on isotype switching. The function of IgA is very straightforward. It serves as a neutralizing antibody. It's going to be able to bind to pathogens or toxins, and that will interfere with the ability of them to bind to the mucosal surface and cause disease. Now, this is a point that a lot of people like to overlook. IgA actually does exist in two sub-isotypes. We have IgA1 and IgA2. Just so there's no confusion, you only find IgA1 in significant levels in the bloodstream, and it is always in its monomeric form, versus IgA2, and this is the one I would circle for the mucosa, it is the IgA2 we find on the mucosal area, and it is always going to be dimeric. The secondary lymphoid tissue that is associated with class switching to IgA is collectively referred to as mucosal-associated lymphoid tissues, or MALT. Now, some of the MALT areas are actually very well organized, just like the organization we see in the lymph nodes or in the spleen, where you have a very well-defined T cell zone, and that's usually right next door to a very well-defined B cell zone. So you see this in tissues like your tonsils or also in the Peyer's patches. Hey, Dr. Muscatelli, do you remember exactly where my Peyer's patches are?
I do not.
You do not remember. Okay, this might be a time to remember where we find our Peyer's patches, because actually the Peyer's patches are the most important secondary lymphoid tissue based on the fact that we see more antigen through our GI tract than anywhere else in the body. Specifically, we find high levels of pyre patches within the ileum of the small bowel. Now, the rest of the molts that we see are basically loose aggregations of lymphoid tissues that aren't as well defined as you would expect to see. Now, some of what we are seeing is based on the fact that memory cells like to home to sites of inflammation, and we tend to see a lot of inflammation along areas like mucosal layers. When they get into these areas, they're going to make up their own specialized lymphoid aggregates. So there might have never been a lymphoid tissue in that area, but I have an inflammatory response. My memory cells are going to home there, and that is going to build a upstart secondary lymphoid tissue. Once I've established an area of secondary lymphoid tissue associated with a mucosa, what you're going to see is a high level of Th2 cells. Recall that Th2 cells we primarily associate with parasites and type 1 hypersensitivities because they release all those great cytokines like IL-4 and IL-5, but also recall that Th2 cells are going to produce fairly high levels of TGF-beta. So Th2 cells that are found within the mucosa will tend to gear more towards isotype switching to IgA. But again, this is a very minimal point. And again, whenever you see Th2, I need you to default back to the fact that it is a parasitic infection or a type 1 hypersensitivity. Now, most of my IgA secreting cells are going to be found within these locations. But you can find some plasma cells that are going to be within circulation that will produce that subisotype IgA1. We still need to address one last aspect of our IgA. Now, if I want dimeric IgA, I want it to be associated with the mucosa. So there has to be some mechanism of transferring my IgA from the basolateral side of my mucosal lining, where I find my plasma cells, to the luminal side, where the IgA will have the ability to neutralize pathogens and toxins in that area. Now, this is accomplished by a unique receptor called poly-Ig receptor. The receptor on the basolateral side of these epithelial cells is specific for the J chain, which is going to be found on my dimeric IgA. Once it binds to the J chain, both the receptor as well as the dimeric IgA is going to be engulfed, and it is going to be transposed across the cell. Once you get to the luminal side of the cell, the receptor actually breaks up into two pieces. And one of those pieces is going to stay attached to the dimeric IgA. And we call this the secretory component. Now, what is tested on isn't necessarily about the process of moving the IgA across the mucosal layer, but rather they like to ask about what is the function of the secretory IgA. And it actually has a couple of very important functions, and I can think of a couple really great clinical vignettes to build this up. One of those might be where I have an infection with a bacteria that has a virulence factor in the form of an IgA protease. Have a friend who always says if a bacteria is worth its weight in gold, if it infects the mucosa, it has an IgA protease. So there has to be a way of trying to protect IgA from breakdown. And again, the protective nature of the secretory IgA is going to be there. It also is going to protect the IgA from being broken down by the proteases that are in our gut. Remember, what do we do in the gut? We digest our foods. We don't want to digest our IgA though. Another important function, and think about this, what happens to everything that goes into our gut. Remember, we put it in one end of our body and it gets flushed out the other end. So why is it that I'm transferring IgA into the lumen of the gut and it is not being literally flushed down the toilet? That comes to the second function of the secretory component. The secretory component has high affinity for mucin and allows for a semi-permanent attachment of the dimeric IgA to the mucosa so it is not lost in high quantities. The last isotype that we need to discuss is our IgE. Now, switching to IgE is going to occur when we have a parasitic infection or, as I keep mentioning over and over again, a type 1 hypersensitivity. Now, class switching to IgE is driven by a Th2 response, and it is the cytokine pairing of IL-4 to IL-13 that allows for this particular class switch. IgE is going to principally interact with mast cells and eosinophils as well as basophils through an Fc epsilon receptor that is present on their surfaces. Due to the fact that we're going to go through hypersensitivities in great detail, we are going to discuss IgE further in Chapter 12.
All right, welcome back to the complement cascade. We know that we've already talked about the alternate pathway for complement activation, which we know was a component of innate immunity. However, complement really so much enhances the immune system. When we're talking about, remember, inflammation, we're talking about C3b, removing these invaders that are extracellular through opsonization, through removing immune complexes. But in the classical pathway for complement activation, this is sort of where humoral immunity, as part of the adaptive immune system, meets the innate immune response. The classical pathway is activated by antigen-antibody complexes, and it is probably the most advanced system of activation. Now, we mentioned both of these points, but they're important points to know. Both IgM and IgG can activate the classical complement pathway, although, as we said earlier, IgM does this more efficiently because the very first complement molecule, that C1, actually needs to bind to two antibody molecules. And because the fact that IgM is a pentamer, we only require one IgM molecule versus two molecules of IgG. Just as we talked about when we went through the alternate pathway for complement activation, I promise you do not have to memorize the entire sequence of either of the complement pathways. But again, I'm just going to highlight a couple of things here and maybe review a couple of important points. Number one, again, the classical complement pathway is initiated by antibody molecules, either two IgG molecules or one IgM molecule, and that sets the classical complement pathway into motion. We are still generating all of the really important effector molecules here. Recall, C3b, going to be a really important molecule for opsonization and for removing immune complexes. And then don't forget about the anaphylotoxins and the chemotactic molecules, C5a, for example, C3a, and here we also have C4a. Finally, culminating in the crazy, not so important membrane attack complex, which initiates at C5 all the way through C9. Again, even though we know that's not the most important function of the complement pathway, we need to remember that it is an important vignette for step one. Now, when we have MAC deficiencies, we will definitely see recurrent Neisseria infections as sort of an indicator. All right, finally, just to sort of summarize this chapter, we have a nice little table that gives you a nice overview of all of the different antibody types. So IgM, IgG, IgA, IgD, and IgE. It reminds you what the exon name is for each of those constant regions, and the approximate levels in the serum. So you can definitely see that IgG is the most abundant antibody in the serum, followed actually by IgA and IgM, whereas you can really not find IgD because it's really not secreted, and you'll only find trace levels of IgE unless, of course, there is some type of type 1 hypersensitivity or parasitic infection. The major biological functions of the antibody types that we've talked about, of course, IgG is really the one that has the predominant amount of effector function. So if you go down the column where IgG is, you'll see that most of the pluses are in this column. Now compare that to something like IgD and IgE, you'll see that IgG definitely has most of the effector functions. One thing I just want to point out is if you look at the naive B cell receptor, essentially you're going to have an IgM molecule, as we talked about, and an IgD, versus the memory B cell receptor, and we talked about this earlier, where you will have only whatever isotype you switch to. So we'll have an IgG or an IgA or an IgE, not all three. We're only going to have one of those. An important point that we're going to come back to in the chapter on immunodeficiencies is that immunodeficiencies that involve B cells are going to present with recurrent infections, usually with bacteria. Again, when we're talking about immunodeficiencies, humoral deficiencies, phagocyte deficiencies, and even complement deficiencies can all sort of initiate with that chief complaint of recurrent bacterial infections. The absence of antibodies within these humoral deficiencies make a severe problem when we're trying to remove bacteria through opsonization because we're lacking that IgG. If we don't have IgG, we can't activate classical complement, especially if we don't have IgM and IgG. So we're definitely going to have sort of a buildup of pathogens and have a really hard time getting rid of them. However, in these humoral deficiencies, it's important for you to remember that T cells are intact and therefore their functions are intact. So their activity against intracellular pathogens, the delay type hypersensitivity response, which essentially is a Th1 response, and your tumor rejection are all normal. It is simply just in a true B cell deficiency, really just the humoral functions that are going to be lacking.